Hello, everybody, and thank you for joining us for tonight's webinar, Medical and Surgical Treatment Options for Common Orthopaedic Conditions. My name is Bertha, and I'm the CPD and Events Manager at CESFN. Before we begin, I would like to acknowledge the traditional custodians and sovereign people of the land across which we work. I recognise their continuing connection to land, water, and community, and pay respects to elders past, present, and emerging. I also extend that respect to any Aboriginal colleagues joining us tonight. Here is a list of upcoming events which may be of interest to you. Please visit our website if you would like more information or would like to register for any of these events. We also run monthly CPR workshop. Again, visit our website with dates and venues for those. Nominations now open for the Primary Health Awards, and the winners receive $2,000 grants towards furthering their work. Nominations close on the 30th of June. You can use the QR code to nominate or for more information. CESFN has launched the Community Services Directory, which is designed to help people in our region better understand the programs and services that are available to them. So I would now like to hand over to Talia from Prince of Wales Hospital, who's just going to give you some information and introduce the speakers. Thanks, Talia.
Thank you very much, Bertha. And a special thank you to CESFN as well for inviting Prince of Wales Private to this educational evening. So I'm the Business Development Manager from Prince of Wales Private Hospital. I've just put my contact details here, including my email and mobile, if you do ever need to reach out to me. A big part of my role is supporting all the accredited VMOs at the hospital. So if there is ever a specialist you'd like to meet in your practice or any questions specifically for our specialists, please do reach out. So there are the contact details there. Just a little bit about Prince of Wales Private Hospital. We are a leading high-level tertiary healthcare facility in the eastern suburbs that specialises in acute surgical and maternity services. We have 168 patient beds, 11 operating theatres and 30 consulting suites on site. And as of this year, we are proud of the 254 active visiting medical officers appointed across 18 different specialties. Last year, we admitted roughly 27,000 patients and had around 1,800 births at the hospital. We have a strong partnership across the Renwick Hospital campus, thanks to our co-location with Prince of Wales Public, Sydney Children's Hospital and the Royal Hospital for Women. I've just popped a little image there on the bottom left, just to give you an indication of our hospital on the campus. And mind you, this campus has probably extended 10 times now with the redevelopment. So we're quite small within the campus, but we are there, and a lot of patients will mention that. But if you go through the main entrance on Barker Street, you'll find our lifts. So today it is my pleasure to introduce you to two of our orthopaedic surgeons, Dr. Jason Chinnappa and Dr. Peter Lorentzos, and they are two of 44 surgical VMOs we have appointed in the hospital in the last 2 years. So I'd like to thank you all for the opportunity to introduce Jason and Peter. Just a little bit of a snapshot of our orthopaedic department. We have 24 appointed surgeons, and last year we treated more than 3,400 private patients. All our specialists subspecialize in a range of subspecialties, including hip and knee, upper limb, foot and ankle, spine and spinal conditions, pediatrics, sports injuries, and trauma. And this year we have introduced the VELOS orthopedic robot for total knee replacement surgery. So I've put a couple of slides together for our two presenters tonight. Dr. Jason Chinnappa is an orthopedic surgeon focused on the management of adult and pediatric patients with problems affecting their hip and knees. Jason completed his orthopedic training in New South Wales and has undertaken 2 subspecialty fellowships in Sydney, as well as an international fellowship in pediatric orthopedic surgery undertaken in Paris. Jason is dedicated to treating patients with hip problems, sports knee and ankle problems in children, adolescents and adults. And what I've included on this slide, please feel free to take a snapshot of his consulting location, as well as how to refer. I've put a barcode in there because Jason has a nice referral page on his website, as well as his hospital appointments and other consulting locations. Dr. Peter Lorentzos is an orthopaedic surgeon with an interest in knee and hip arthroplasty, sports knee injuries and trauma. Peter completed his orthopaedic training in New South Wales and is now appointed as a VMO at the Prince of Wales Hospital. Peter is also a Chief Medical Officer for a first grade Sydney Rugby League team and has an outstanding interest in sports and sporting injuries. Also on this slide, please feel free to take a snapshot. We've got Peter's consulting location, as well as how to refer to Peter and hospital appointments and other consulting locations. So without further ado, I'd like to introduce Dr. Chinnappa for his first presentation. Thank you, Jason.
Thanks, Talia. So thanks everyone for having me, and Bertha and Lauren for putting this on. My name is Jason Chinnappa, and I'm an orthopedic surgeon who specializes in hip and knee surgery for adults and kids. Finished my training in Sydney and did a hip and knee fellowship under Dr. Michael Solomon before moving to Paris for a year to work at the kids hospital there. And now I'm back seeing kids at Sydney Children's Hospitals and both adults and kids privately. I have no conflicts of interest to make other than I really like orthopedic surgery. We'll get started a little bit about why we're talking about adolescent sporting injuries.
More and more young people coming through with significant knee injuries.
Football, rugby, netball, you're increasing your risk of an ACL injury.
Injuries is always bouncing up in the muscles, and ACLs are definitely one of them.
Young people are spending a significant proportion of the time in front of their screens.
It's not good, is it? It's quite frightening, actually. You hope that people look after themselves and actually prepare right to look after their bodies.
There's an increased ACL injury rate in women and girls compared to men and boys.
There's no doubt that there are gender biases out there.
The biggest mental impact is not being able to play the sport that you're talking about.
I don't let my patients go back for 12 months.
You lose a big part, a big chunk of your life.
I'm fed up, to be honest, of having that conversation.
So sport's such a big part for kids these days, and rightly so, that, you know, a big sporting injury in their teenage years can be quite devastating, both professionally and socially for them. Kids are playing more and more sports, which is why we're seeing more and more injuries these days. And we'll just get started into another video just to wake everyone up. And
An aerospace engineering major.
Such an impressive young lady.
Let's see how high she flies right here.
Yep. Ooh.
I think she may be hurt. It looked like that ankle came down very awkwardly, and she is obvious.
so I don't think it was her ankle that was injured, but, you know, this is a common scenario that we see people who land from a jump and feel their knee twist. And here are some scenarios that you might see presenting in your office. So the patient might report that they heard a crack or felt a pop and had fairly quick swelling off the knee, or they felt a sharp pain and had gradual swelling off the knee, or they felt a click and now they can't straighten the knee. So 3 quite common scenarios we see after a sporting injury, and we'll just delve a little into what some of the common differentials are for these. So they heard a crack or felt a pop and had fairly quick swelling off the knee. Now that could be an underlying ACL injury or a fracture or a patellofemoral dislocation. They're probably the big 3 that we would think about. If they landed, felt a sharp pain and had some gradual swelling of the knee, often that's a sign they've had an underlying meniscal tear, or they may have an underlying osteochondritis dissecans lesion. And if they felt a click and now they can't straighten their knee because they've got a mechanical block, that might suggest a displaced meniscal tear or an osteochondral lesion or an osteochondritis dissecans lesion. So as you can see, I mean, all these scenarios have a range of differentials, so trying to figure out what it is can be challenging. The initial history may point you some clues in which way you might be thinking. So with the scenarios we discussed, first of all, are they able to weight bear or not? If they're usually unable to weight bear, it does typically signify a bigger injury or a significant hemarthrosis, and especially significant fractures of the knee, they're very unlikely to be able to weight bear. Was this a traumatic injury or not? Has there been any recent change in activity? If there's no trauma involved and they start complaining about knee pain after sports and you can't pinpoint what it is, that's when you'd be thinking of something a bit more subtle, like a patellofemoral injury or osteochondritis dissecans. Do they have a past history of any of these conditions? Because if they do, chances are that's probably the most likely causing injury this time. The location of the pain can be useful if they can pinpoint it, but often, as you know, they'll say the whole knee hurts. But what can be helpful is, does it radiate? Does it come up into the hip, the thigh, the groin, or does it go down into their foot? Is the knee swollen? And do they have any mechanical symptoms such as clicking or catching? And is it painful? Because a lot of people have painless clicking of the knee, and that's usually not a red flag at all. Are they having any giving way symptoms of the knee? So initial examination, if they've got a large swollen knee, generally implies something significant is going on, and you have a low threshold for arranging further imaging if the first investigations are normal. Don't forget to check the hip, because a lot of knee pain can be referred from the hip, and we don't want to miss a hip injury that's presenting as knee pain. If in doubt, a plain X-ray of the hip can give you a lot of information. Areas of tenderness, I'll normally palpate along their extensor mechanism, so from the quadriceps to the patella, to the patella tendon, to the tibial tubercle, or along the joint lines, or along the collateral ligaments. Now, again, they might be sore everywhere, but sometimes trying to find out which area is a little bit more sore than the others can be quite helpful. Stability and meniscal testing. Now, I must say, usually if they're presenting with an acute injury, it's really hard to get them to A, relax, or B, if their knee's very swollen, it can also limit their assessment. So this you might be able to tell a little bit further down the track. It's often very hard to do right in the acute first presentation. In terms of imaging workup, knee x-rays are a must for most of these, because if there's an obvious fracture or a dislocation of the kneecap there, you A, want to reduce the dislocation, but B, you may not need any further imaging in the form of a CT or an MRI. If the x-ray is normal and they've got a knee effusion, I think an MRI is a must. It'll give you all the information you need underneath. CT knees, probably more useful if we're planning fracture surgery. It's not really very helpful at diagnosing most of these injuries, which are largely ligamentous, if the x-rays are normal. And then long leg alignment x-ray is something that I will use for planning surgeries in some kids in particular. And don't forget a hip x-ray, again, especially if they come back with a normal knee MRI and they're still complaining about knee pain, I'll definitely get some imaging of the hip. And these pictures just show you typical AP, lateral, and skyline x-ray here, with the patella, the kneecap, sitting in the groove for the kneecap. This is not a fracture. This is the closing growth plates of the proximal tibia, typically closes from the back to the front, and the tibial tubercle is the last to close. So you can get a fracture through this, but if they're not sore at the tibial tubercle, it's not a fracture. So some examples for an x-ray might be useful. So this x-ray of a patient who's still growing, as you can see by their growth plates open, shows what looks like just a small fracture here, but this is actually attachment off the ACL. So this is an ACL avulsion fracture, and these need to be fixed, because otherwise they end up with a lax ACL and the problems that are associated with this. A CT can be useful to try and identify little flecks you may see on x-ray, and your examination suggests there's something more going on. This is an example of a PCL avulsion fracture at the back of the knee. And if there's a decent piece of bone there, these avulsion fractures can be fixed with screws like other fractures and restore the ligamentous stability of the knee. This is an example of long leg alignment x-rays, which these days can be done with EOS machines, which have significantly lower dose and great accuracy at giving us measurements for this. And this just shows the difference in alignment before and after guided growth treatment, which is an option for growing kids to help avoid problems with their patellofemoral joint in particular. And this is the reason, don't forget a hip x-ray. This is an example of the slip capital femoral epiphysis on the left, and often these kids will have knee pain as the presenting complaint. And a lot of them will have gone through courses of treatment for knee tendinopathies and things like that, because the imaging is normal and it's actually coming from their hip. Just some more examples of imaging and what we look at. So this is an MRI knee showing an ACL rupture. Whenever we see bone bruising here at the back of the tibia and here around the middle to the front of the femur on the lateral side, this signifies an ACL injury, as that's the only way that this tibia can rotate and hit the femur here. This just shows another slice showing discontinuity of the ACL fibers over here. This is an MRI showing a discoid meniscus, which we'll talk about in a little bit, but it's effectively a very thick meniscus that's bigger than it needs to be and is prone for tearing. A patellofemoral dislocation, this is an example of that, and this shows a loose piece of cartilage as a result of that, and is the reason why we would recommend an MRI for all first-time patellofemoral dislocations. This is typical location for an osteochondritis dissecans lesion, and I know we're just flying through some images now, but this is just to get these keywords in the back of your mind, and we'll talk about these conditions in a minute. So ACL injuries, I'm not going to talk too much about these because I think Peter's got an extended section on this, but the treatment, especially in kids and adolescents, it's usually operative. ACL stability is very important for protecting the menisci and the cartilage. And unlike older adults who are going to follow instructions and may avoid sports where they will run into instability episodes, there's no way you can limit some of these kids from not playing with their friends and putting their knee through its paces. So it is quite important that kids have a stable knee following an ACL injury. I guess the main difference between the younger patients with ACL injuries, it comes down to their growth plates and how much growth they have remaining. So depending on how much growth they have remaining determines how much risk you might be putting their growth plates at. And if there's a lot of growth left, the last thing you want is to just do a standard ACL reconstruction that affects their growth plates, leads to ongoing worsening deformity that needs more treatment. So typically for kids and teenagers that I see who still have open growth plates, we'll try and figure out how much growth they might have left. And so some of the things we look at are their skeletal age. Now we can work that out based on an atlas of left hand x-rays that's been done many, many years ago. And the radiologist will look at this x-ray of the left hand and compare it to charts which show for each month which ossification center should be open, which ossification center should be shut, and give it the skeletal age to tell us, is that the correct same as their patient's actual age? And typically we go by the rule that girls grow until age 14 and boys grow until age 16. And so putting those together can get an idea of how many years of growth this child might have still to go. Pubertal growth spurts can be useful for, sorry, I'm just checking the chat. Pubertal growth spurts can also be useful for how much growth they might have left. For girls, have they had menarche already? If they have, they usually don't have too much growth left. If they haven't, can still expect a lot of growth to still come. Patients' heights relative to their parents, and we try and just get an idea. There's no one test that we would look at that would be useful to say this is how much growth they have left, but piecing all of these together, get an idea of how much growth is left. Some other things we can look at are pelvis x-rays, knee x-rays, and there is a newer knee MRI staging atlas, which I've begun to use, which is also very accurate and saves you having to order extra hand x-rays and things to give you an idea of patient's age growth remaining. The biggest thing with this, like the video said at the start, is the pre-op counseling of the long recovery and return to sports times. Typically, these kids are out of sport for 9 to 12 months as a minimum, and that's a long time to try and miss out on their social sports for the weekends, or if some of them are semi-professional, that could be the end of their professional career, having this injury at a young age. So most of the time, the first consultation is just they're in shock, and it's I'll often arrange a second follow-up appointment even before any surgery, because that's when they'll actually be in the right frame of mind to discuss the surgery involved. So going back to how much growth is remaining, this is just a simple algorithm that has been published and I tend to follow. So for younger kids who have more than 2, definitely more than 3 or 4 years remaining, We try and do our best to not actually touch any of their growth plates. And so this is one example of using the iliotibial band as a non-anatomic extra-articular and intra-articular ACL reconstruction. This is all done with sutures. There's no fancy buttons or anything like that. And we typically use this for kids who have a lot of growth remaining. If when they're older, they have another injury, you can then still treat them as a standard ACL, and there's no bone tunnels or anything like that that are going to be complicating factors. An alternate to this that has been published is what's called an all-epiphyseal technique, where you do a short ACL that sits above this growth plate and below this growth plate. So that's an alternate to this. For kids who have a moderate amount of growth remaining, you can combine them and do a standard-ish tunnel in the tibia and stay below the growth plate here, because our usual ACL, which exits like this, will tend to go right on the periphery of the growth plate on the femur here. And if it stops that, that can lead to angular deformity. This is an example of what that looks like, the combined hybrid method. And in kids who are a little bit older, we tend to go through both growth plates like we would in an adult, but making sure that we don't use any bone block grafts, and we also don't exit right here. So we do use intraoperative imaging to make sure that we're fairly central through both tunnels, which minimizes the risk of causing a growth disruption. And these kids should all also have follow-up until skeletal maturity with those long leg EOS x-rays to look for growth disturbance. Again, Peter's going to talk a little bit more about different graft options, but the one thing I'll say is in kids, we don't use the bone patella tendon graft, because by putting a bone block across the growth plate, you will definitely cause a growth arrest, whereas soft tissue grafts do not cause growth arrests across the growth plates. And I think Peter's also got a section on lateral extra-articular tenodesis, but it is an augment that we can do to reduce the risk of ACL rupture, particularly in young patients returning to high risk of pivoting sports, which is effectively all teenagers, and is otherwise also used in revision ACLs. So the results, look, the literature for this is quite variable. Typically, we say that the younger kids are, when they injure their knee, the more likely they are to re-rupture it. But then when you actually look at the literature, the rates are all still, just around 10% or so, which is also the quoted re-rupture rate for adults. But the one big thing is that a lot of them will have growth disturbance. So this does require follow-up and addressing any growth disturbances as it occurs to avoid a leg deformity. So patellofemoral instability or dislocations are the big thing we see that's associated with sporting injuries. A lot of these patients will have sort of maltracking and clicking of their knees, but no pain or symptoms until they have a traumatic event. Initially, they'll complain of pain or apprehension, both before the dislocation, but once a dislocation occurs, that's when pain becomes a bigger factor. Always recommend getting an MRI after the first time patellofemoral dislocation relocation episode to look for any cartilage fractures, because these do sometimes need semi-urgent surgery to repair them. If there's no cartilage fractures, or this is a second time and their knee's not that swollen, physiotherapy management is definitely very appropriate in the first line, focusing on both knee and hip strengthening and patellofemoral taping. Non-operative treatment is largely successful in the majority of patients, but if they get recurrent dislocations, then we would have a look at different treatment options. So we've got, if they're very knock-kneed, guided growth can be useful to slow down the growth on one side of the knee, let the other side grow more, and correct them from a knock-knee position to a straight or slightly bony position, which is protective of kneecap problems. And if they've got problems with their anatomy to do with their patella height, we can do an osteotomy to move the tibial tubercle, or if they've still got open growth plates, we can do a soft tissue version of that where we just detach the patella tendon and put it where we want instead. And then there's medial patellofemoral ligament reconstructions for those who don't have any underlying bony deformity to account for their problems. And again, there's pediatric versions of that we can do to respect the growth plates and not lead to growth disturbances. So this is an example from earlier of a patient who had knock knees and had patellofemoral instability. So we were able to use just 2 small plates on this side of the knee to tether these growth plates, let the other side keep growing so that their knees become from knock knee to straight. And we would have left this a little bit longer in this patient before taking them out. And just an example of what moving a tibial tubercle further down so that the kneecap sits further in the groove looks like. Meniscal tears in kids. So most meniscal tears in kids, if it's not associated with an ACL injury, will be related to a discoid meniscus, which is a congenital malformation where the meniscus is thicker and covers more of the articular surface than normal, and it's almost always the lateral side. More meniscus does not mean better meniscus. In fact, it actually leads to increased tearing and instability of the meniscus because it no longer has that cushioning effect of a shock absorber. It just works as one big cushion in there instead. Initially, they will have no pain and just clicking and clunking symptoms on the outside of their knee. X-rays might show increased joint space on the outer aspect of the knee. And an MRI will show, instead of the typical bow tie pattern, we see almost a big rectangular appearance on multiple slices. When these are picked up initially with clicking alone and no pain, treatment's just to observe, but warn them that if they start getting any pain in that area, they need to be reassessed because they are prone to tearing. It's much easier to deal with these if you catch them early. There is no role for prophylactic surgery to treat the discoid meniscus, as when they'll actually end up with a tear is very variable. And some patients may not have any symptomatic tears in that meniscus till they're in their 40s or 50s. And so they definitely don't need surgery when they're a teenager for this. Non-discoid meniscal tears are probably a little bit more aggressive than in the adult population. So if it's an undisplaced tear, we'll still monitor it for healing and make sure it's stable in a repeat MRI 3 months after the injury before letting them go back into sport. And if it's a displaced meniscal tear, then we'll be recommending early surgery, as kids are usually more suitable for a meniscal repair and preservation rather than letting them wait till they're more symptomatic on it and then needing to debride meniscus. And this is an example of what an intraop picture of a discoid meniscus in a tear in a 7-year-old girl looks like. So normally we shouldn't be seeing meniscus covering half the lateral plateau here. This is all extra meniscus with the probe in the tear between the normal meniscus and the torn meniscus. And after getting rid of the extra meniscus, you're left with the peripheral meniscus as it should be. And the second part of my talk's a little bit about osteochondritis dissecans. It's a condition that you may have heard of, but not know too much about. I know we certainly didn't learn much about it early on in our training, but it's more common than you think. It's a disorder of subchondral bone, so the bone just underneath the cartilage, that then leads to a problem with the overlying cartilage. We don't know exactly why it happens. We think it might be to do with repetitive microtrauma or decreased blood supply to that area. The exact incidence is unknown because symptoms can be so vague and can be very variable in actually getting to diagnose it. But in a Swedish study, they found that it was 6 in 10,000 was their incidence, and it is more common in males than females. Affects teenagers more than other age groups, and typically affects your active teenagers who are playing sports, which makes it very hard to get them to rest. It commonly affects the knees, but can also be seen in the elbow and the ankle joints, usually not in the same patients, but it's a similar pathology in those joints. And the symptoms are usually pretty vague to begin with. There'll be pain, stiffness, swelling, maybe some giving way, catching symptoms, which could be a sign of any of the other pathologies we've actually discussed already. So examination is also similarly inconclusive. They're a little bit sore, maybe around the area of the osteochondritis lesion, but it can also be quite normal examination with symptoms only after sport. So X-rays can identify some of these lesions, and this is an example showing the typical described lesion which occurs on the lateral or the central aspect of the medial femoral condyle. So here it just looks like this may be a little lucency or shadow here, and you can see that here as well. little, looks like a small cyst. But MRI is the gold standards and necessary for all X-ray confirmed, or if you suspect it and can't see much on X-ray. Not just for diagnosing, but it's what we use to monitor the progress of the lesion and helps guide treatment. So this is an example of the same case, what it looks like on MRI. So you've got cartilage, the bone underneath, which looks like it's got a little bit decreased blood supply. You've got inflammation between the bone, that bone, and the surrounding bone. Now, this is one of the earliest stages, but over time, these can progress. This is an example of one that progressed. And now we've got fluid behind the lesion, a lot more bone bruising. And on a CT scan of the same thing, because this is all cartilage, it looks like a big void. It's not, but it does show that some of the bone over here is quite missing. So the natural history of these lesions, if you leave them and they don't heal, so they go from undisplaced stable lesions like we saw in the previous slide to an undisplaced unstable lesion. So that involves fluid tracking behind that lesion because there's been some separation of the cartilage, to a displaced lesion, which is repairable. So something like this, where there's still cartilage and bone, but it's no longer sitting where it should be, to an irreparable displaced lesion. So one where this bone's been eaten away because it's not being attached to anything for a long time. And then arthritis is the end result, because if you imagine that's quite an important part of your weight-bearing section. So if that's worn out, articulating with the tibia here, you can end up with arthritis at a young age. So treatment management. So again, similar to ACL injuries, the hardest part of this is keeping these kids still. So set expectations and goals early and tell them they are not playing any sports for 6 months. This is a slow healing process. It's not a normal fracture or anything like that. So it needs time. And non-operative treatment, which we use for the stable lesions, is very successful at healing the majority of these if the kids are young with lots of growth to go. And so the treatment involves offloading that area. So we'll get them to use crutches to limit their weight bearing, cease sporting activity. If it involves the patellofemoral joint, which is a rarer lesion, we'll lock their knee out straight to rest that joint from moving. And then I'll arrange a repeat MRI 3 months after the treatment starts to assess the lesion. If the lesion is getting better and their pain is getting better, then we plan for a gradual return to activity over the coming months. If the pain is not better or the lesion looks worse, then we discuss operative treatment option for them. Operative treatment, there's a variety of treatments that are described. The simplest involves just drilling the area of affected bone to stimulate blood supply, and we can use those same drill holes to do fixation as well. And then this is an example of picture showing a drill with fixation with an absorbable pin. If it's a displaced lesion that's been present for a long time, I'll usually do an open debridement behind the lesion with some bone grafting and then fix it in place, because usually the first go at trying to fix these is your best go. Afterwards, if we're going back in because things have not healed, we're having to look at more invasive procedures of taking cartilage from elsewhere to plug it into this site. And the surgical indications, as we discussed, so if it's an unstable lesion, so there's fluid tracking behind it, it's very unlikely to heal. So I'll recommend surgical treatment of those. Or if they've had 3 months of symptoms that are not improving with non-operative treatment, then I will also recommend surgical treatment with a similar rehab to non-operatively, and definitely no sports for 6 months. These kids all feel better after the surgery and want to get back to doing things, but it's a matter of keeping them still, because these are very small, fine 1.5 millimeter pins that are going there. They look big, but this is all magnified. And this is an example of the surgical approach. So using a probe, we can find where the cartilage is soft, which corresponds to the underlying diseased bone, drill those areas, and you don't have to use pins, but you can put absorbable pins in if you want. I guess summary of my talk, specifically focused to referrals and things. So ACL injury, I generally recommend they see a physiotherapist for some knee early rehab, and then see a surgeon if it's a displaced meniscal tear, I'd recommend seeing a surgeon first up because their knee is probably going to be blocked and unable to rehab with the physiotherapist. If they've got a meniscal tear for a younger patient, I'd also recommend early referral as they may benefit from early surgery because younger patients can have their menisci repaired. Fractures, recommend splinting them, keeping them off it. They might need DVT prophylaxis. So typically kids don't get blood clots, but teenagers and that adolescents is a gray area. So they're the patients I might consider using some DVT prophylaxis in and orthopedic referral. Dislocation of patellofemoral joint, recommend arranging an MRI. And if there's a loose piece, orthopedic referral. And physiotherapy is going to be useful in surgical or non-surgical treatment. And osteochondritis, they need to rest, they need an MRI to assess the lesion, and orthopedic referral, so we can run through non-operative, operative based on the MRI findings and bring them the bad news about how long they're going to be out of sport for. Thank you all. If you have any questions, post them here, or if you want to email me directly, that's my email address there. And thanks for your time this evening.
So I'll introduce Dr. Peter Lorentzos now for his first presentation. Welcome, Peter.
So ACL injuries in young athletes. So a little bit about me, mostly knee, hip and trauma. I work in a couple of different hospitals, Prince Wales Public, private and Westmead, consulted a number of locations, have a big interest in sport, and have been involved in sport for a number of years. So I was the West Tigers Chief Medical Officer for 10 years and finished last year, and have moved across to the Bulldogs as of this year, so Chief Medical Officer there. And for a while I was the New South Wales Swifts netball team Chief Medical Officer as well. My contact details are in the bottom left if you want to take them down, or so I guess this talk, so a little bit about the ACL and what it does, recognizing the imaging, various graft options, and a little bit about lateral tenodesis or lateral loop. It used to be popular once upon a time, went out of fashion and has come back in fashion. So case one, young high-level rugby league player, non-contact pivoting injury, which is nearly how most ACLs are. Somebody's running, changing direction, they feel their knee give, or it feels like it dislocates, they feel a pop, they get significant pain, they get swelling that comes on pretty rapidly, and generally an ACL injury is what you find. And so I guess for these high-level athletes, is just a standard ACL reconstruction good enough? So with an athlete, what do? You want them to return back to the same level. You want them to avoid a re-rupture, and you want them to have a stable knee. So all the data seems to show that not every athlete who does their ACL will automatically go and play at the same level. The figures are anywhere between 60 to 90% of athletes will return back to the same level. So it's not always a given. The last thing you want is for an athlete to re-injure their ACL, because it takes a good 9 to 12 months to return from one. Your career is generally pretty short. If you do it again, that's a significant time away. It takes a toll on you, both physically, mentally. The guy before we saw, the West Tigers guy in the photo, he had 3 ACL tears. So the incidence of ACL injuries, so ACLs account for the most amount of sporting knee injuries or significant knee injuries. They're increasing, and the people at greatest risk are young people, so generally 15 to 25-year-olds. So what is the ACL? So it's one of the major ligaments in the knee. It's very important in knee stability. So you can see that ligament there that we see through varying degrees of flexion is the ACL. The AM and the PL are just what we know as 2 separate bundles, but if we can think of it as sort of one ligament in in essence, and you can imagine if the front of the knee is to the left of the screen, what it does is it prevents the tibia sliding forward. So you can imagine the tibia trying to go towards the left, even further anteriorly. The ACL is like a little seatbelt and stops that happening. So when it ruptures the ACL, the tibia translates anteriorly a lot more, but it's also important in rotational stability. So without the ACL, the lateral side of the knee advances a little bit further forward on the femur than the medial side. So it sort of rotates. So the consequences, these are fairly well known. You know, it's difficult to return to any sort of pivoting, cutting sports. The knee feels a little bit unstable. You get repeated effusions, and it eventually, like Jason says, leads to meniscal damage, which then leads to cartilage injuries, which eventually gives you a very difficult knee to manage. So injury mechanism is usually, like I said before, it's a non-contact pivoting injury where the tibia translates anteriorly while the knee is slightly flexed and in valgus. So if you think about it, it's kind of the knee is in and the toe is out. An exaggerated picture is what you see on the screen. This is probably more than just an ACL. It's probably an ACL, MCL, and maybe even something else. So examination, we don't need to go through that. So stuff to recognize on an MRI. You can see on the left of the screen is an intact ACL. It never really looks as dark as the PCL when you're looking at it, but you can see sort of fibers that are taut, that are dark, that look like they're going in one direction. On this one here, you don't see that. Another thing that you can recognize on imaging is this classical kind of bone bruising pattern. It's like a kissing type lesion. So this bruise here on the lateral femur, and this other bruise here on the posterolateral tibia. It's a classic sign. If you see that, you almost know they've done an ACL, and that's because as the tibia, the lateral part of the tibia slides forward, this part of the femur whacks that back part of the tibia, and the only way for that to happen is for the ACL to rupture. So generally, these people are sore, and they're sore on the lateral side more so than the medial side. So picture on the right shows you what happens. Another little thing that we sort of more hear about than actually see, not very common, is what's called a Sagon fracture. So on a typical X-ray, you see this little flake of bone just above the fibula on the actual lateral aspect of the tibia. It's really an avulsion fragment from a ligament on the lateral side of the knee. So if you see that, you know that there's been a pivoting type injury where the lateral side has been stretched, and it's almost pathognomic for a ACL injury. So what do? We've got various graft options. So we think about it generally as in, you know, the grafts that come from us. So autografts, whether we use hamstring, patella tendon, or quadriceps. Then we think of using cadaver grafts, so allografts from a deceased person, or we use synthetic ligaments inside the knee. Now, in terms for an athlete, you're almost certainly not going to use a synthetic ligament. They've kind of gone out of fashion. Cadaver grafts or allografts in young people and in athletes have higher rates of re-rupture. So you try to steer clear of those sorts of grafts. So you're sticking really with autografts. And the most commonly used ones are hamstring and patella tendon. So what's hamstring? By far and away the most common graft that's used. Usually we use either semitendinosis by itself or a combination of semitendinosis and gracilis. We take the tendinous portion, we strip the tendinous portion and use that, and then clear it of muscle, fold it over and use that as our graft. In a lot of patients, this actually does grow back, never the same quality, but in about 70% of people, it does grow back. So why is it so popular? The surgery is much faster than patellar tendon. It's, the morbidity is really low. You can actually, if you take, say, the semitendinosis and fold it over 4 times and add gracilis, you can get a really thick graft to use. And you don't really affect, your extensor mechanism. So you're not touching the quads or the patella or the patellar tendon. So the pain is in the first few weeks is not as great. Disadvantages. So even though I said you can get a big graft, sometimes it's less predictable. So it's not unusual to see somebody who's quite large, and when you find their hamstrings, they're actually quite skinny. So then you're a little bit stuck, because you're stuck you're committed to using a small graft. Because you're taking the hamstrings from the medial side of the knee, theoretically you can make that medial side of the knee a little bit looser. So, if you've also got an MCL sprain, then you're losing some of those dynamic structures that help keep the knee from going into valgus. Because it is a hamstring graft, you're waiting on tendon to bone healing when the graft integrates. So it takes longer than patellar tendon. It takes about 12 weeks for it to start to integrate. And importantly, and very importantly, is even though the re-rupture rates are low, they're higher than using bone, which is what we call the patellar tendon graft, because we take a little bit of bone from the patella, the middle third of the patellar tendon, then we take a little bit of bone from the tibial tubercle. So bone, patella, bone, the advantages. So it incorporates really fast because we're relying on bone to bone healing. Like a fracture, it heals in 6 weeks. It's very strong, and the revision rates are not quite half of a hamstring, the re-rupture rate is not quite half, but it's close to. The disadvantages, the problem is the disadvantages are significant. We hear about anterior knee pain, so pain on kneeling, pain at the front of the knee. That's probably spoken about more than actually really happens. And the way it's done now is a little bit different to how it used to be before. Once upon a time, when you took the little bone bits out of the patella and the tibial tubercle, you just leave them blank, leave them empty. But now we fill them up with bone graft, so there's no real divot you can feel. Makes kneeling on it a little bit better. And that does help, but you still have that risk. There's a risk of suffering a patellar fracture, and that's not during the surgery. That's after, while in your rehab. It's very rare. It's less than 1 in 1,000, but it does happen. And I remember years ago when I started at the Tigers, just before I started there was a footballer who'd had patellar tendon ACL as a revision graft option, and at about maybe would have been about 6 months post-surgery, just straight line running in his rehab at about 80% speed, just had a patellar fracture. He was a very, very, very talented player at the time, playing NRL. He never advanced beyond that. Another patella, he had his patella fixed. He was never the same afterwards. Because you end up with a decent longitudinal wound, like a knee replacement, you end up with a little bit of numbness on that lateral side of the wound, because all your superficial skin nerves go from medial to lateral. And so you get a bit of numbness, but most people don't really worry about that. And certainly athletes aren't interested in that sort of stuff. They just want whatever's strongest. And they're not concerned about the other stuff. And like Jason said in his talk, you can't use it in people who are skeletally mature. So generally males under 16 and females under 14. So the registry data, unfortunately in Australia, we don't have a registry. We do for knees and hips and shoulders and all the other stuff, but there are some countries in the world that do have a registry of ACLs. So Scandinavian countries, New Zealand. So every ACL that's done, how it's done, what graft is used, the risk of re-rupture. Generally, you know, it's hard in Australia because if you do an ACL reconstruction, they rupture and they don't come back to you. You've got no way of knowing that they've ruptured and had a revision. So this graph shows you. Quads tendon is the orange, still very low and has always been quite low. The blue is using a hamstring graft, so going down and then sort of plateauing out a little bit. The green is patella tendon, so slowly increasing, but not significantly so. This is a percentage. And the yellow is what we call graft length. So graft length is using a hamstring tendon, but using it in a different way, where you only sacrifice one tendon, but loop it over 4 times and get a really thick tendon and no need to use more tendons. So overall graft survival, this is again from the New Zealand registry, shows you that as time progresses, patella tendon outlasts hamstring. Now, this is a very important slide. So in young people, revision rates or graft failure, you know, overall, like Jason said, graft failure is about 10%, but it's very high in young people. And if you look at hamstring versus BTB, under 20s, you've got 12% versus 2.7%. In 20 to 24s, you've got 10.3 versus 4. So about half in bone, patella, bone. So in summary, in the Scandinavian countries, hamstrings have 2.3 times the revision rate of BTBs, and in the Scandinavian ACL registry, so much the same, hamstring nearly double the revision rate. So can we do any more to decrease revision rates? So as Jason touched on, there's a lateral tenodesis. So what a lateral tenodesis is, once upon a time was popular, then went out of fashion, but is coming back in, especially used in people who are high risk of re-rupturing. So high-level athletes, people who are ligamentously lax, young females, people who, when you examine them, feel very loose, or any kind of revision setting, you definitely don't want it to happen again, so you do it. Now, you see this, there's multiple ways of doing a lateral tenodesis, or what's also called a lateral loop, but really the whole point of it is to tighten up the lateral side of the knee, because that's the knee, remember, that's the part of the knee that pivots further than the medial side, pivots more anteriorly. If you look at this blue line here, it's what's called the ALL. It's a very skinny, very small little ligament in the knee, and that's what avulses and causes that second fracture on the lateral tibia when the tibia goes forward. You've got the LCL here, which is your lateral fibular collateral ligament. One way of doing a lateral tenodesis is taking a centimeter of ITB, lifting it off the tibia, passing it underneath the lateral collateral ligament and re-putting it back on the tibia. So you can imagine then this little middle loop here, when the knee's extended, has to sort of not quite go at a right angle, but it's sharp bend anteriorly. And if the knee's about to sublux, it works like a little seatbelt to stop that tibia subluxing forward. So it's like a little secondary restraint for the ACL you make. What do we know about lateral tenodesis? So the risk of re-rupture is decreased by 60%, and it also decreases rotational laxity by 38%. So sometimes you can fix an ACL, and sure, you may reduce the anterior translation of the tibia, but you may not fully eradicate that rotational rotational motion of the tibia on the femur just by your ACL reconstruction. And if you don't, the athlete will certainly struggle to return to sport. Once upon a time, young people used to come back at 9 months, but we've sort of slowed that down, and anyone who's young, we've kind of increased the return to sport to about 12 months now. And certainly, and that just seems to reduce re-rupture rate. I guess you can even go from 12 to 18, and that'll decrease it even more so, but at some point they have to go back to sport. That's the end of the first talk. Okay, meniscal roots. I'll go through this pretty quick. So again, a relatively new concept. Not new as in a couple of years, much longer than that, but very different from a normal meniscus tear and much more significant. So generally, this is sort of the normal person you'll get it in, say middle-aged female, getting off a bus, standing up from a chair, feels a sudden pain in the back of the knee and feels a pop. And then when you see them, they've generally got this vague pain at the back of the knee. So if you hear a pop, you're thinking, you're certainly not thinking an ACL in this age group and from that mechanism, but I've seen it so many times where they describe that exactly, and they've got a meniscus root. So if we can get this out of it, what's a meniscal root? Why is it so important? And what's a treatment plan? So meniscal root tears, what are they? So we know meniscal roots, menisci, a little C-shaped fibrocartilage in the knee, and they work as little shock absorbers in the knee. There's a smaller lateral one and a bigger medial one. And you can imagine they're mostly attached at these middle bits, like little kind of, that's their roots, where they're attached to bone. And as the femur above presses on these, they want to sort of expand sideways, but the meniscus has fibroelastic properties and it can only go so much and then bounces back. And that's what gives your knee the shock absorption. So you can imagine if you damage one of these roots, you almost completely lose that shock absorption. So the role of the meniscus, so it increases the joint congruity, as you can kind of see in that picture to the right. It helps with shock absorption, lubrication, proprioception, stability. And you can imagine as the knee joint and the femur and the tibia squish together, the meniscus, like on this next slide, wants to go outways. It can only go so much and then springs back. If you cut the meniscal root or it's torn, you completely lose that shock absorption. So studies show it's almost like doing a subtotal meniscectomy and taking out the whole meniscus in terms of your prognosis. So once you lose that, you lose the hoop stresses that the meniscus supplies. The cartilage then has to automatically take on hugely increased loads, which it's not been accustomed to. And it leads to accelerated arthritis of the knee. So equivalent to a total meniscectomy. These are some of the quoted figures that seem extremely high. So up to 28% of patients with a meniscal root tear can undergo a total knee replacement at a mean of 3.2 years. So that's huge. So somebody who's had moderate compartment arthritis gets a meniscal root, and then it's the writings on the wall. They're they'll almost certainly have a knee replacement in 5-6 years. So the absence of meniscus leads to a huge increase in risk of a total knee, and it can occur in young patients. The mechanism is very different. So the incidence, they only account for about 10 to 20% of meniscal tears, and often undiagnosed. Usually it's when the knee's in deep flexion, occasionally a little bit of a rotational component. Medial meniscus tears are the ones that you'll get in, middle-aged people, 40 to 60, usually female, usually overweight, usually a little bit of varus in both knees, and usually have what an MRI report will say, grade 1 to 2 chondral changes or grade 2, chondral changes in the medial compartment of the knee. The lateral meniscus is usually the result of a traumatic injury, often associated with an ACL and previously under-recognized. So this is really just a simple classification, not really to know. It's just for us when we describe meniscal root tears. Is it, a partial? Is it a complete? Is it a complete root with a bucket? Does it involve bone? So history and exam. History, I think, gives it away more than an exam. You just have to have a high index of suspicion when you get that, flexed knee, feels pop, pain at the back of the knee that you never really had after a very sort of benign kind of mechanism. Feel a pop, minimal mechanical signs. So the MRI, so it leads to a few things. So sure, you get a bit of fluid around the meniscus tear. You see some meniscal extrusion. You see a ghost sign and a tear and a radial tear. So I'll go through them. So you see here how the meniscus, let me just see. So not as significant in this scan, but the meniscus, because it's lost its attachment, seems to translate a little bit more in the medial gutter than it will normally. Normally it'll sit a little bit further in. If you're looking at the coronal images and you go towards the back, you see the lateral meniscus come all the way, and then if you go another slice back, it attaches here. If you look at the medial meniscus here, this is where the root is, and you see some white in between. White is just fluid, so a fluid signal in between, the meniscus indicates a tear. What you'll also see when you're going through the sagittal images, you'll go slice, 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 and then at some point you'll go slice, slice, you're seeing meniscus, then you don't see any meniscus, then you see the root later. So, you go slice, slice, then through this image here, you see nothing, which is called the ghost sign. Now, the treatment algorithm is, firstly, I guess it depends if it's an acute traumatic tear. If it happens acutely, it's a young person, well, you need to fix it because, as we saw, the consequences are devastating. If it's one of these chronic degenerative ones where you've got a little bit of early cartilage wear in that compartment, it's really almost a case-by-case basis. So you kind of look at it, you see how much arthritis they have. If they don't have significant arthritis, then and the meniscus is repairable, then it's worth a shot at repairing. But you need to explain to them carefully that once they have a meniscus repair, they're going to be on crutches for about 6 weeks. They're going to be in a brace. If they're definitely not that sort of candidate, then it may not be worth pursuing surgery. So So contraindications here they've got is somebody with subchondral collapse, grade 3+ defects, malalignment, varus valgus, or other reasons for instability. Surgeries, not very difficult. Here you can see a meniscal root tear. It should be attached there. Put some stitches in here, grab that meniscus, drill a little bone tunnel, pass the sutures through and tie them over the bone. Then it really is non-weight bearing, bracing, and hoping that that meniscus will heal. This is a picture of a repaired meniscus, grabbed and then into a bone tunnel here. This is the rehabilitation, just so it is important. Sometimes you'll see like I said, you'll see somebody and you think they're not going to manage 6 weeks non-weight bearing. So it's almost not worth pursuing and just putting somebody through all of that just for the gain you're going to have. That's the end of that talk. Knee replacements, very common. This is how many knee replacements, 886,000 as of like a year and a half ago in Australia. And there was an increase of 57,000 total knee replacements in that year. And this is all going from the Australian Joint Registry. So every knee replacement that is done, there's a record of it. It's submitted to the registry. It's well maintained. Everything about that knee replacement is put down on record. The implant, how it's done, the reason it's done, the equipment you use, little things like have you resurfaced the patella, have you cemented it, have you cemented only one component, just everything about it. And then we go on and keep every record. Then they go back and retrospectively look at them, assess them and see if there's any outliers that we need to kind of be aware of, any implants that aren't faring well, any implants that are faring well, and they guide our practice. So overall, knee replacements are increasing. Overall satisfaction is about 80 to 90%, which sounds high, but often isn't, because there's a good 10 to 20% of people who are not happy with their knee. And it's a big procedure to go through to end up with, 1 in 10 or 1 in 5 people that are not happy. And often, a lot of these people are people who you look at the x-rays and you look at the function and you think, well, there's nothing really wrong with this, but they're just not happy. And so every effort's made in terms of using various alignments, using these robots, using navigation, using everything to try and eke that up from 80 to 85 to 90 to even higher. Survivorship is easily greater than 90% at 10 years, greater than 80% at 20 years. You can do it in any age, but the younger age and males are associated with increased revision rates, increased risk of infection in people who have high ASA and high BMI. And generally you think when we do a knee replacement, we change the distal femur and the proximal tibial joint surfaces, and that's a prerequisite, but not everybody changes the patellar articulating surface. And if you don't change it, that's also associated with increased revision rates. So by gender, not hugely different, but generally more females than males are getting knee replacements. This is a graph from the registry data showing the general use of new technologies. So the red line is how we've used to do them a long time ago. And actually not even, if you look at 2003, nearly all knees were done not technology assisted. And that's how we probably all trained. Navigation came in early, and has sort of started to plateau and go down a little bit. Then we've got IDI. IDI is a term for using so image guided implants. So, for example, getting a CT or an MRI pre-surgery, and then having a 3D cutting mold made that will fit that particular specific knee. And during the case, you know, before you cut off the distal femur or proximal tibia, you put that guide on, and it should fit onto that joint surface, and it'll have a little slot where you put the saw, and all the hard work is done. It's just you put the saw in, it cuts it where you want, and you're done. That's what IDI is. And then the green is robotic, and you can see that's increasing, you know, at a linear line over a very short period of time. So new trends. So navigation's a way. So if you see that on one of the op reports that gets sent to you, navigation's a way of putting markers in the bone, and these things are kind of like spatial markers. And you know, we use a tracer, we feel the outline of the bone, and it puts in a computer a three-dimensional picture, and then we can alter our cutting guides and put them in any degree of varus, valgus, flexion, you know, decide how much we're taking off, and it gives us an interactive picture on a screen. We put our cutting blocks, then we cut. PSI guides are what I mentioned earlier. These are 3D printed guides with little saw blade cuts. So you expose the distal femur or tibia, you pin these things on, and then you pass the saw through, and then you should be pretty much done after that to just put the knee in. What do these show? So 30% of knees are done this way. Navigation shows no difference at the moment in terms of outcomes or revision compared to just the normal traditional way we used to do it. PSI guides do show a slightly higher rate of revision over 65-year-olds, unfortunately. Robotic knee replacements, there's at least 5 different robots on the market. They're not, you know, the robots that we see on Hollywood TV, but they're essentially machines that use some sort of CT or MRI or X-ray imaging, and then pressure monitors to tell us exactly where the knee is and what the joint is doing in flexion and extension, and then it'll give us various numbers, and when we're happy, it'll just cut the bone, and then we put our implants in, and it's done. So a really very, very, very important thing about knee replacements is having a nicely balanced knee that, you know, in extension and in flexion feels nice, feels like a natural knee, isn't really wobbly on one side, isn't really wobbly on the other side, isn't sort of stiff in flexion and tight in extension. You know, you want somebody to be able to have a nice, smooth gliding knee that feels as close to a normal knee as possible, and they have good range of motion. It can come out straight, it can bend to, you know, 120, 125, 130 degrees. The robot that Prince of Wales Private has is this Velis, which is a very good robot, very good at using pressure sensors. And I think they're thinking of getting this other one, the Mako, at some time in the very near future, which is good. Personalized implants are so robotic knees don't really show any difference in terms of outcomes or revision compared to knees, how we used to do them once upon a time, not very long ago, the traditional way. Data is very early though, because they haven't been around very long. So time will tell, you know, the next 5-10 years will tell a lot. But at the moment, there hasn't been a significant skew in terms of way better or way worse. Personalized implants, that's another new thing that can be done now. You can sort of go get either an MRI or a CT of your knee and have a knee molded, a metallic mold made of your knee with PSI guides made, whether it's in France or Switzerland or the US. They'll ship it in. It comes in a small little box, and you'll put the PSI guide on. You'll make the cuts, and then you'll have a knee that is specially made for you and fits nobody else, only you, and put onto your knee. So that's still very new, but being done. There's a number of different companies that do it. It's got its advantages and disadvantages. Still too early to know if it makes a big difference or not in terms of revision rates. Yeah, but some people like the actual thought of having their own knee rather than knee that comes off the shelf, labeled size A through to G or size 1 through to 8. And that was just really a background. So when you see an op report or whatever, and it's robotic or navigated or PSI, you kind of have a bit of a gist of what it is.
Thank you, Peter. We've had a question come through for that presentation. So is a knee replacement needed if the patient has bone on bone? So the person who's asked has a patient who has responded very well to physio and quad strengthening.
Yeah. So, so the answer is probably no, actually. So you'll see, and you'll have patients who you'll get an X-ray and it's minimal to moderate arthritic changes, and they're struggling. And you'll see, not unusual to see, a 70-year-old lady come in with, who's bow-legged, terrible bone on bone, and still functions. So it's a combination of radiological stuff, but also symptoms. So if they're struggling to enjoy the activities they enjoy, if they have to think 2 or 3 times before they go, I'm going to play with the grandkids, I probably won't do that, or I don't really want to go to the shops because my knee's sore, or it's waking you up at night, or it's sore getting in and out of bed, then that's probably the time to do it. Not so much when an X-ray says bone on bone. Yeah.
Thank you. And just from your earlier talk as well, what do we achieve by doing operation on athletes? Do they and can they go back to their original state?
Yeah. So an athlete who's playing pivoting or cutting sports like league, union, netball, almost any sport, without an ACL reconstruction, they can't really go back. But having said that, even if you do an ACL reconstruction, the general perception is that most people will go back to their sport, but not everybody does. And certainly it's only anywhere between 60 to 80% of people ever return to the same level. So you may be, for example, an NRL player, and post ACL, you may go back to, for example, reserve grade, but you may never feel confident enough to go back to that same high level. Yeah, so that's a disappointing thing. Yeah, not every operation is the same. Not every patient's the same either.
Thank you. A couple more for your knee replacement presentation. Is pain the main indication for a total knee replacement?
Yeah, I think pain, instability, but generally pain's the most common one. Yeah.
And then just regarding the earlier question, over 50-year-old with posterior knee pain and a pop, the MRI is not rebatable. Should we strongly recommend an MRI nevertheless in case there's meniscal root tear?
Yeah, that's a difficult one. Yeah, actually, very good question, because like we saw, the consequences are huge. I think if you've got a history where they actually feel a pop, they've got pain in the back of the knee, and they've got a mechanism of like a flex knee at the time, and when you see them, they're sore. And for example, say you see them a few weeks later and they're still sore, then it's probably a reason to get a scan. They're going to be very different from your other meniscal tears. They're not really going to have the clicking, catching, locking that some of the other tears do. But if you're worried, if the symptoms persist, it's not a surgery that needs to be done, in 1 or 2 weeks. You can wait a little bit, but if you wait too long, the consequences are bad. But you can wait. You can wait 4 or 5 weeks, see if they settle down, and if they don't, then get the scan. Yeah.
I guess, Peter, you could also probably add that these patients will probably have not really much arthritis on their X-ray, so that will help differentiate them from your typical degenerative meniscal tear.
Yeah, good point. Good point.
And can you just talk about the conservative treatment of knee osteoarthritis, for example, steroid or Synvisc injection? I hope I pronounced that correctly.
Yeah. So I guess there's a certain path everybody, we use regular physio. Weight loss is probably the most important. Physio, so quads strengthening, glute strengthening, that helps. Stationary bike is always great. Avoid impact activities like, you're not going to pick up distance running. Then you think about simple analgesics, paracetamol, anti-inflammatories. Then I guess the next thing is injections. And so what do you do? I guess I think about them in sort of 3 different groups. There's cortisone, there's Synvisc, which is hyaluronic acid, and then there's PRP, which is your own blood centrifuged down and re-injected into the knee. So cortisone is the cheapest. You can go anywhere, you can get it. It's probably the most got the most predictable results. You can buy 5 vials of cortisone for $20 at the chemist, and you're going to get predictable results. I guess the side effects with cortisone are the biggest of the 3. You're not going to give somebody cortisone every 3 months for the next few years. It has side effects in the knee. It has general side effects. It causes, chondral erosion, bone softening, all that sort of stuff. So I'd limit it to a couple of cortisones in one joint. And then if they need more than that, well, they really need to get to the next level of treatment. Synvisc or hyaluronic acid is very good. Generally, it's for mild to moderate arthritis. Generally, it gives you around about 6 months of pain relief. Doesn't really do anything inside to the knee, but it's kind of like getting an oil change in the knee. You inject a really thick viscous substance, and it seems to help with symptoms for plus or minus 6 months. Not really many downsides. The cost is expensive though, and access is expensive. So it costs anywhere at cost like about $400 or $500 a vial just to get. So when I do it, I warn them that, there is a cost to it. The third one is PRP. So PRP is in the last sort of 10 years has become very popular. At first, evidence was kind of lacking on how good it was, but evidence is starting to catch up a little bit that it does seem to help in mild to moderate arthritis. Even some people who've got more extensive arthritis. So you take a vial of your blood, you spin it down, you take the top platelet layer with a little bit of serum on the top of that, and you inject it in the knee. It can be done sort of a complete inexpensive cost zero method, but you can also have it done at any imaging place like Castlereagh or IMED. There are vials around that you can get from various companies that are single enclosed loops where you take the blood, spin it down, and then re-inject it into the knee. The cost is cheaper than Synvisc, and generally, I think you need about 2 or 3 per year. So the cost does, though, add up. There's one that I've been using recently, not for just in my normal practice, but I use it for footy players. It's a combination PRP and Synvisc, which seems to help a little bit. And I know Castlereagh uses the same one. So none of them are going to make you feel great or make the knee feel back to what it was, but it helps. And it really is just a way of sort of getting you through until one day they stop working and then you get a knee replacement. But, those things, that Synvisc and that PRP and the Synvisc PRP combination, we use routinely in footy players, 20-year-olds, 25-year-olds, just to get them through week by week.
Thank you, Peter. And just a quick question, is an MRI rebatable if requested by an orthopaedic surgeon? Do you know?
I think it is. So my secretary seems to get them rebatable. She just calls and books them in, yeah.
I think
Jason?
it depends on the machine. Each of the private providers' machines have different rebates attached to them. Some will rebate specialist referrals, and some there's still a different fee associated with it.
Yeah. So that's exactly right. So I think it's got to do with a licensing agreement with the government. So, for example, even if you go to Castlereagh, they will have 2 machines, for example, at St Leonard's and 2 machines at Westmead. One is a rebatable machine and one is not. So you can get your MRI done that day if you're prepared to pay, or you will wait a couple of weeks to get into a week or 2 weeks to get into the rebatable machine.
Okay, great. Thank you very much, Peter. We've just got some feedback, another excellent talk. And if you're happy to share your slides with Bertha and to all the attendees tonight, that would be very helpful.
Oh, pleasure. I will.
Thank you.
Thank you very much, everyone. Thank you for staying.
Great. Thank you. Thank you to our presenters, Talia, for organising the talks from the hospital. And thank you to all the attendees for joining us tonight. Enjoy the rest of your evening, and don't forget to fill out the evaluation survey. We'll share out the resources once we receive them. And thanks everyone again for your time. Good night.
Thank you very much.
Thank you. Good night.